here's something that doesn't get said enough in a doctor's office. A negative Lyme test does not mean you don't have Lyme disease. I know that because it happened to me. I had the rash, not a vague redness, not something I had to squint at. The textbook, concentric ring, unmistakable bullseye rash. I had headaches that wouldn't quit, night sweats soaking through the sheets, a stiff neck I couldn't explain, vision changes that scared me more than anything else. I went to the doctor, they ran the test. Negative. 10 days of doxycycline. Come back if it gets worse. It got worse. And what came next, both what happened to me personally and what the research says about why it happens, is exactly what this channel is going to be about. Welcome to TikTok Research. This channel exists because I went through the Lyme diagnostic nightmare, came out the other side, and spent a serious amount of time reading the research that explains exactly why that nightmare happens, and why it keeps happening to so many people. Every video here is grounded in published science and clinical guidelines, and in the real experience of patients who've lived this. Subscribe because this is going to be a long conversation, and we're just getting started. Let's start with the basics, because most people have no idea what their doctor actually ordered when they tested them for Lyme. The standard test, the one recommended by the CDC, the one used in virtually every clinic in the country, is called two-tier testing. Here's what it does. Step 1. A screening test called an ELISA looks for antibodies in your blood. Antibodies are the proteins your immune system produces when it detects a pathogen. If that screening comes back positive or borderline, a second test, the Western blot, checks for specific antibodies to the Lyme bacteria, Borrelia burgdorferi. On paper, that sounds solid. The problem is this: the test isn't looking for the bacteria itself. It's looking for your immune system's response to the bacteria, and your immune system needs time to mount that response, typically 4 to 6 weeks after infection, before antibody levels are detectable. So, when I walked into that clinic, weeks after a tick bite, with a bullseye rash and a stiff neck and vision I didn't trust, my body hadn't had time to produce the antibodies the test was designed to find. The test didn't find Lyme because it wasn't looking in the right place. It was looking for a reaction my immune system hadn't finished building yet. This isn't a rare edge case. There are 3 distinct windows in the disease timeline where standard Lyme testing routinely fails, and understanding them explains why so many patients end up exactly where I did. Window 1, too early. In the first 2 to 3 weeks after a bite, your immune system hasn't produced enough antibodies for the ELISA to detect. Testing here is almost meaningless. But this is exactly when most patients first see a doctor, because this is when the rash appears. The CDC's own guidance acknowledges this. A negative early test does not rule out Lyme. Window 2, wrong timing. Even if you're past the early phase, if the test is run before the 4 to 6 week mark, results can still be falsely negative. Many patients are tested once, sent home reassured, and never retested at the appropriate time. Window 3, partial treatment. This is the one that catches people off guard. If you receive antibiotics, even in an inadequate course, those drugs can suppress the infection enough to blunt your immune response. Antibody levels drop. A test that might have caught you before treatment may now come back clean. Not because you're better, because the test can no longer see what's still there. That third window is where I lived for a long time. 10 days of doxycycline, not enough to clear the infection, but apparently enough to make the standard test stop seeing it. Negative result after negative result. While the headaches continued, the night sweats continued, and something that felt like it was affecting my vision and my neck just quietly got worse. The test wasn't lying exactly. It was just only capable of telling part of the story. Here's something I learned later that I wish someone had told me at that first appointment. The bullseye rash, erythema migrans, is considered so diagnostically reliable that multiple major clinical guidelines say explicitly, if a patient presents with a bullseye rash in a tick-endemic area, you do not need to wait for a test result. The diagnosis is clinical. The rash is the evidence. Treatment should begin immediately. I had that rash, and I was tested anyway. And when the test came back negative, the negative result carried more weight in the room than the rash that was visible on my skin. This happens because not every clinician is trained in the nuances of Lyme diagnosis. It happens because the two-tier test has become a reflex. Order it, read the result, act on the number. When the number says negative, the conversation often ends there. But the guidelines are clear, and the biology is clear. A bullseye rash with a negative early test is still a bullseye rash. The rash doesn't become less real because the antibodies aren't there yet. Now here's the part of my story that I think is the most important, and the most underreported. After months of getting worse, I eventually found what the Lyme community calls a Lyme-literate doctor, a clinician who specializes in tick-borne illness, understands the testing limitations, and knows how to look beyond the standard two-tier result. They ran a more comprehensive panel, an MDL panel, that looked at multiple pathogens simultaneously. What came back wasn't just Lyme, it was Lyme, Bartonella, and Mycoplasma, 3 infections. And for all those months of negative tests and worsening symptoms, nobody had tested me for 2 of those 3 organisms. Not once. This is the part of tick-borne illness that the standard test is completely blind to, because the two-tier ELISA and Western blot test for one thing: Borrelia burgdorferi. It tells you nothing about Bartonella, nothing about Mycoplasma, nothing about Babesia, Ehrlichia, or Anaplasma. And ticks are not single pathogen carriers. A single bite can transmit multiple organisms. In some regions, research suggests that somewhere between 1/3 and nearly half of Lyme patients carry at least one co-infection. The co-infections don't just add their own symptoms. They intensify the overall illness, broaden the symptom range, and make standard treatment fail. Which brings me to why my symptoms looked the way they did. The headaches and stiff neck, classic neurological Lyme involvement, but also consistent with Bartonella's neuropsychiatric reach. The night sweats, a hallmark of Babesia, but also seen in Bartonella. My body was fighting something that wasn't on anyone's radar. The vision changes, one of the more alarming symptoms, and one that often signals neurological or vascular involvement that standard Lyme treatment alone won't resolve. None of these symptoms in combination fit the joint pain and bullseye rash picture that most people, and many clinicians, associate with Lyme. And that's exactly why they kept getting explained away. 10 days of doxycycline is the kind of prescription that feels like a real answer. You walk out of the clinic with something in your hand, something is being done. But here's what that prescription was actually doing, and not doing. Doxycycline is an antibiotic effective against Borrelia, the Lyme bacteria. It is also effective against Ehrlichia and Anaplasma. What it does not treat is Babesia, which is a parasite requiring entirely different medication. And what it does against Bartonella at a 10-day course is, at best, incomplete. Bartonella often requires longer treatment with specific regimens, sometimes rifamycin-based or macrolide-based combinations, for weeks or months. So I was given one drug for 10 days, targeting one organism, when I was carrying 3. The math on that was never going to work out. This is not a criticism of every prescribing physician. Lyme and its co-infections are genuinely complex. The research is still evolving, and the standard guidelines are built around uncomplicated early Lyme. The problem is when the standard approach gets applied to a situation that is not standard, and nobody catches it. The good news, and there is real meaningful good news, is that the testing landscape is improving. In 2025, researchers presented data on a new AI-enhanced blood test for Lyme disease. Unlike the current 2-tier system, this single-tier test uses machine learning to detect Lyme across all stages, including those earliest weeks when the standard test is essentially blind. Early data shows it significantly outperforms current testing. It isn't widely available yet, but it's the most significant development in Lyme diagnostics in years. Specialized labs are also now offering multiplex molecular panels, tests that use PCR and next-generation sequencing to search for the DNA of multiple tick-borne pathogens in a single blood draw. Borrelia, Babesia, Bartonella, Ehrlichia, simultaneously in one test. These panels are more sensitive for chronic and low-level infections where antibody-based tests go dark. And a 2024 study documented human co-infection with Babesia otocoileae, a species of Babesia that standard tests weren't designed to detect, alongside Bartonella in chronically ill patients. The implication: even our co-infection testing may be systematically missing pathogens we didn't think to look for. The expanded panel that finally gave me answers exists in this category. It's available. The barrier isn't the technology, it's knowing to ask for it and finding a clinician who knows how to use it. Let me bring this home practically, because information without action isn't much use. If you have a bullseye rash, treatment should start immediately, based on the clinical presentation alone. Do not let a negative test result override what is visible on your skin. If your doctor is waiting for a positive test before treating, push back, or find another doctor. If you were tested in the first 2 to 3 weeks and got a negative, ask to be retested at the 4 to 6 week mark. Make sure your doctor understands why the timing matters. A single early negative is not a clean bill of health. If you were given a short antibiotic course and are still symptomatic, a repeat standard Lyme test may still come back negative, not because you're well, but because the partial treatment has suppressed your antibody response. Ask specifically about co-infection testing: Bartonella, Babesia, Ehrlichia, Mycoplasma. Ask whether an expanded molecular panel is appropriate. If your symptoms include neurological signs, headaches, stiff neck, vision changes, cognitive fog, burning nerve pain, psychiatric symptoms, name them explicitly. These are not standard Lyme presentations. They are flags for neurological involvement and potential co-infections that require a different conversation. And if the standard system isn't getting you answers, Lyme-literate physicians exist. They understand the testing limitations, run comprehensive panels, and are willing to treat based on clinical presentation when the standard labs come up short. Finding one was the turning point for me. It may be for you too. I started this channel because I kept meeting people who were exactly where I had been: sick, told they were negative, running out of explanations, and I realized that the research explaining what was happening to them existed. It just wasn't being translated into something usable. That changes here. If this video helped you understand something you've been trying to make sense of, share it. The person who needs it most probably isn't searching for it, but someone in their life might send it to them. Subscribe for the next video. We're going deep on co-infections, how they interact, why they are missed even more than Lyme, and what treatment actually requires. I'll see you there.